So yeah, this is a Meet the Cohort session, which is part of the Propel program. So my name is Tim East. I'm the digital navigator on the program. So this session, we're pleased to have with us 3 suppliers that are part of the Propel program. So we've got Hummingbird Medical, Promatica Digital, and Your Meds. So I'm recording the session. So we'll circulate that after the session. I'll do a quick introduction in terms of the Propel program and what it is and who's involved, and then we'll hand over to the 3 suppliers, and I'll introduce each one of them as they go through their section. So yeah, the Propel program is a 6-month program. It's an intensive support program for SMEs and startups in the health tech sector. It's in its 3rd year now, so we currently have 10 suppliers on the program, and it's centered on 5 key sort of knowledge pillars, which are understanding the NHS landscape, governance, growth and spread strategies. That's the first pillar. Then we've got funding and investment, legal and compliance, networking, mentoring and support. So yeah, we've got our website. So if you Google Propel YH, you'll no doubt come to it. And then we've got a LinkedIn page and a Twitter account. So any information, you can go to those channels, as well as a YouTube channel. And this recording will be put on the YouTube channel. It's delivered in conjunction with our partners. So Hill Dickinson provides legal guidance, Barker's Eagle Labs provide finance and funding support. It's based at Nexus, which is a business centre with links into Leeds University and also Leeds City Council. And we also have input from a number of other organisations, including Thrive by Design, Orca and British Business Banking. So if you have any questions, we'll have time at the end. If you want to pop your questions in the chat, we'll pick them up after each supplier's had their time. So I'm pleased to hand over to Dr. Rakib Chowdhury, who's a GP in Leeds, and he's the founder of Hummingbird Medical. So I'm sure you'll see that Rakib's got an innovative product called Book Your GP, and this is aimed at intelligently managing and coordinating patient recalls. So I'm happy to hand over to Rakib if you want to run through your offering.
Absolutely, yep. Thank you for having me. I'll just try and share my screen. Let me have a look. Screen. Yeah. So can everyone see this?
Yep.
Yep, fantastic, great. So I've shared my screen correctly. So a quick PowerPoint. I'm not going to go through a lot, but probably just a quick overview. So I'll just start with a little story, and this is essentially how we got started in this. Well, when I was a junior doctor, this was around 2016, 17, around that time. I was in a large GP surgery in Leeds, and there was a chap who came in with back pain, and you know, about 1 out of 3 people in the UK get back pain at some point. And this chap was kind of your typical back pain patient. So he seemed all muscular, nothing too worrying, but he kept on coming. Saw a few of the GP partners and was given some painkillers. When he came back, they decided to do some blood tests. And then the patient didn't attend for his blood tests. And he kind of got lost to follow up, essentially. A few years later, the back pain was even worse, kind of keeping him up at night, stopping him from getting to sleep and things. Had the blood test, and it turned out that the patient had metastatic prostate cancer. So this patient took 3 or 4 of the GP partners to court, basically, and yeah, it was just a very traumatic experience for the surgery, of course, and you know, it made me think there's probably a lot of these types of cases going on all through the UK, and I was thinking, you know, is there a way of actually using software to automate reviews, coordinate care, and improve communications between surgeries and patients. And there's loads of cases. So I've got a few case studies here. I'm not going to go through all of them, but I think just to illustrate what we're dealing with, it's a good idea just to have a chat about a couple. So these are all real cases, and I've got a bibliography at the end of this if people want to have a look. But yeah, another case is a 53-year-old gentleman. He's tired all the time, has blood tests, and is anemic, which is a bit of a red flag when it's a male and he was over 50. GP did the usual thing, asked the team to contact the patient to attend for further tests. Patient didn't arrive. Patient arrived 6 months later for a follow-up and was referred under the cancer referral pathway and was diagnosed with colorectal cancer. Patient sues all of the GPs that were involved in the care. The reason is that if you don't tell patients why they need the follow-up explicitly, then it's the doctor's kind of responsibility, and the burden of proof falls on the GPs or the doctors or the surgery's shoulders. I won't go through all of these, but I think this is another interesting one. So it's a 52-year-old lady. She asked for a home visit because she's feeling dizzy. Junior doctor goes to visit her, feels like the blood pressure might be a bit low, causing the dizziness, so stops the medication. A week later, the patient is still dizzy, so calls for another home visit. This time, the senior GP goes and visits and notices that she's on lithium, which is a kind of a mood stabilizing medication, but very toxic. So the GP decided to do a blood test, which was meant to be done every 3 months. Essentially, after a lot of back and forth, the levels come back very high, and the patient gets admitted to hospital urgently due to lithium toxicity, but the patient's left with permanent ataxia and dysarthria, meaning that she can't move properly or speak properly. So she sues everyone, including the GP, the junior registrar as well. It's just a taste of what's going on in primary care. I mean, we deal with 90% of patient contacts, and we prescribe the most medications out of the whole of the NHS. And this kind of sums it up. So according to NHS Digital, litigation is increasing by 10% a year in general practice, and medical comorbidities are going to double over the next 10 to 15 years, according to the ONS. And none of the solutions are very good at dealing with this. We're using systems which are 20 years, 30 years old sometimes, to kind of manage this. And the complexity, as the comorbidities increase, the complexity increases, because multiple comorbidities means that instead of maybe 1 or 2 reviews a year, you might now have 4, 5, 6 reviews a year. So it's very complicated. So the solution, in our opinion, was to make good software, and we think that we've gotten quite far. So we're currently serving tens of thousands of patients in Yorkshire, and we've had very good feedback. I'll give you a quick demo of the app. So the app is called Book Your GP. This is a test server with all fake patients and fake patient data, so there's nothing being breached. In the app, we'll walk through it and we'll do a very quick tour, but the app has a full calendar system, and it has a full kind of disease and cover system. It'll all make sense as we go through it, but the app comes preloaded with all sorts of diseases and risk stratifications and vaccinations preloaded into it, and you can set it however you'd like. So if I click a hypertension with a blood pressure over 159, so it's a risk stratified group of patients, you can set what you would require doing at each review. You can set staff profiles. So our example nurse here, she can do the following things. So the app knows who can do what and how long different conditions and tasks take. And we have a fully fledged kind of calendar system as well. Probably don't have time to go into all the ins and outs with this one, but it's very kind of intuitive, and it has like all the functionality you require. You can essentially add diseases to different appointment slots. So again, patients can get recalls and then book directly into the appropriate slot, because the app knows who can do what and how long each thing takes. We'll jump straight to the recalls page, because that's probably where the majority of the work happens. Again, this is all fake data. So when you go to the recalls page, it's just a big list. In the outstanding tab, you have a list of patients that haven't had their reviews done and are due their reviews doing, and you can communicate with the patients directly from here as well. So, for example, if we want to send Marnie a PIT, a quick recall, you could just click the text message, say, you are due a review at the surgery, please contact us. And then say that you want to contact the patient again in about a month's time or 2 months' time. It's up to you. We'll do a month, and you can just put that date in and click send, and the text message will get sent off. When that happens, that patient will now end up in the pending tab. This is where all the patients who have been contacted will appear. So, for example, this patient is now here. You can see you've contacted the patient once, and you can see the message you've sent and when the patient will reappear in the outstanding tab. Once the recalls are sent, everything gets recoded into the electronic health record so that the surgery gets paid for their QOF or CCSP contracts or any other contracts they have. And we also have a full kind of vaccination list, all your smears and baby vaccinations, all your shingles vaccinations, 70 to 80 on there. Your app is very malleable. So it means that any kind of thing that the surgery would like to monitor, it can be put on the application. So, for example, if there's a GP with a special interest in diabetes, and they say, okay, anyone with a foot ulcer needs to be reviewed, every few months or every 6 months, then you could put that onto the app. So you can put anything you want, and the app has everything on it. So if we go to the search tab and we search like methotrexate, which is a controlled immunosuppressant drug, it will show you who is due the methotrexate, but it's calculated it for the whole of the year. So you can do some workforce planning as well, so you know who is due what and when. If we go to the recall settings, you have a lot of features here, and you can tweak the recalls basically. So if, for example, amiodarone, you want to do an ECG, which you're meant to do from time to time, you can add that in there as well. And the app essentially listens out for when the patient has had an ECG or a user-knees, in this instance, in the patient record itself. So there's no way of tricking the system. It's completely medico-legally robust. So if the patient cancels or DNAs an appointment, the patient will continue to get recalled into the surgery. And there's a automate feature as well. So if you want to automate, for example, your amiodarones, and say you want to contact 2 or 3 patients a day, you can just set that in and the patient will get automatically contacted. So you can automate your disease registers as well. So in a few surgeries now, we're already automating amber drugs and high-risk disease, high-risk diseases like CKD4/5, so end-stage renal failure. And you have a whole host of other features as well to help you get on with your work. So probably out of scope for today, but that's basically a quick kind of whistle-stop tour of the whole app. You can, one last thing which is pretty cool, you can do ad hoc recalls as well. So if you find, if you go to patients, all of your patients will be on there for your surgery, and you can just click on one of them and you can add your own recalls in, of course. So if you want to do a blood test, and you want it to be a user-knees, for example, again, and you want it doing it in 3 months' time, again, this will just get automated as well if you choose it to be, and the patient will get recalled in for that. So it's completely kind of medico-legally robust system. Right, and so jumping back to a little bit of the presentation, there are a few findings. This is just a quick pivot table we made for a surgery that will remain anonymous, but this is very typical of what we find. We find that the majority of patients out there have some kind of monitoring requirement that isn't done. So these are the years. So 2018 to 2022, we calculated it for surgery with our application. You can see that in 2018 there were 737 recalls out of 5,365 which were due and have not been done. And if you click on this, you can see which disease registers were missed out. So there are a few scarier ones in there, like there's someone with heart disease with a blood pressure of 159. There's a few diabetics, 3 diabetics with an HbA1c over 75. There's all sorts of blood thinners which obviously should be being monitored. And this is very typical. We haven't ever found a surgery that has less than 30% of patients who have gone missing to follow up. So it's a really big problem that we think needs to be addressed. When we analyzed the data and how well the app's working, and we find that our application saves about £4,000 per 1,000 patients a year. So it's quite a large cost saving. Savings due to phone bills being reduced, letter costs being reduced, and text messaging being reduced, because all of our services are being provided by the government, so everything is at cost. So it's much cheaper than what surgeries are using now. Also, the administrative work is massively reduced as well. Obviously, there's reduced workload as well, and less work for GPs and admin teams and less meetings. This is an audit from a couple of years ago when I was a GP partner, and we found that we did a quick kind of audit over a month, and we found that the app did about 70 recalls. We saved about 31 GP appointments as well. A lot of these were because of better communications with patients and better safety netting. And that's kind of it. It's just a snapshot of the sources if you'd like to have a look. But yeah, that's the end of my presentation. So I hope that was quite interesting. And yeah, if you've got any questions, I'd love to hear.
That's great, Rakib. Really interesting offering. It's a clear user case of bringing value to primary care. So I've just got a couple of questions. So in terms of your current projects, what projects are you actively involved with at the moment with your product?
Yes, so we are in quite a few places now, and so we're at about I think probably about 7 or 8 sites in Leeds at the moment. Each surgery is obviously quite different. So one surgery in Leeds is probably the furthest ahead, and they're automating a lot of things, and they're just adding one disease register every month. So they're automating CKD4/5, methotrexate, mycophenolate, some of the blood thinners. The next, they're going to be doing some of the other more kind of high-risk disease registers. We've launched it in a smaller surgery recently who are now using it for all recalls, including ad hoc recalls. And then we are also in, thanks to the AHS, and thank you very much, we're actually working with the chair of Rotherham CCG as well. So we're in 3 sites across Rotherham, serving about 15,000 patients there as well. And again, I think they're just trying to grasp the scope of the work because they are big, more complex. And I think what we do for the larger surgeries is that we systematize how they do their recalls. One of the problems is that currently a lot of this stuff is knowledge-based. So what happens is that there'll be someone in charge of doing this stuff and keeping an eye on things. But obviously people retire, people leave, and people are unwell. And then when that happens, the whole system that they have in place often kind of disintegrates. So we see our platform as a kind of, a framework for the surgeries to work off of. And it retains the knowledge, so it means that the organization can function even without, certain key people. It can continue to work safely and effectively.
Mm-hmm. Yeah, that makes sense. What are your ambitions for your product in the Yorkshire and Humber region? Sounds like you've got some interesting projects already in flight, but
yeah, well, I think our main aim at present is that we want to obviously get bigger. It would allow us to get more revenue to build more features, and we want to obviously integrate with the main electronic health record suppliers as well, which we'll hopefully be doing later on this year. I think that's kind of like short-term goals. I have to say the integration hasn't been much of an issue because it is all automated already for the surgeries, meaning that they're not having to do what they currently do, which is like export and import a bunch of files. Everything is done on their behalf, including all the read codes. So those are kind of short-term goals. I think the long-term goal would be hopefully kind of making healthcare just more decentralized. There is no reason why you cannot have like health pods or get help from third parties like pharmacists who are hooked up to our app. So if you are a hypertensive patient and you just need a blood pressure check, why is it that you have to come to the GP surgery for a face-to-face or buy your own blood pressure monitor? don't see any reason why you can't, go into a health pod. You get recalled through the pod. You can choose where you want to get your blood pressure done. It could be at your local pharmacy. It could be in a local health pod of some such, and everything gets fed back into the patient record. And I think that would be the long-term goal, and just trying to make healthcare more accessible for people who are working, not currently where they're GP, where they're registered with. I think it would have a very big impact on a lot of different aspects of healthcare if we manage to do that.
Mm-hmm. Yeah, and how can people contact you for any follow-on discussions, conversations, etc.?
Yes, so you can just email me directly. I think maybe the people who are present on this call would probably get my email. Alternatively, you can just go to our webpage. So you can go to hummingbirdsmedical.com. There's a contact page there. If you send it there, I'll get the message. So if you would like to have a chat, I'm more than happy to talk with you.
That's great. Thanks, Rakib. So we'll move on to Maisie, who's the commercial executive at Promatica Digital. This is a supplier that's, again, based in Leeds on our doorstep. They have a number of products, but today Maisie's going to be talking through her Social RX product, which is a digital social prescribing platform. You okay there, Maisie?
Yep, thank you, Tim. I'm just going to share my screen. So, hello everyone, my name is Maisie. I am commercial executive at Promatica Digital, but the reason why we're in the program, the Propel program, and what I wanted to show you today is our social prescribing tool, Social RX. So for those of you who don't know what social prescribing is, I'll just give you a quick overview. Currently in the UK, 1 in 4 GP appointments are for non-clinical issues. This could be things like loneliness, housing, or financial concerns. Instead of prescribing these patients with something in a tube or a bottle, GPs can refer them to a link worker who works with the patient to find out what matters to them and what services are available that could help them improve their well-being. Things like lunch clubs, counselling, support groups, and these are all based in the community. The problem at the moment is that social prescribing is getting a lot of traction over the past few years, but with all the new link workers that have been hired, they're using Excel spreadsheets to manage their cases. They have a lot of admin work to do with contacting community providers and managing their cases. And also they're struggling to prove the benefits of what they're doing. Without a lack of data, obviously it's hard to get the funding. So what Social RX is an award-winning social prescribing case management software tool that allows link workers to better manage their cases and make referrals directly to community providers with our internal directory of services. It allows GPs to make direct and simple referrals straight into social prescribing, and also self-referrals can come in, or third-party professional referrals, so things like social care, ambulance services can make referrals as well. Also in Social RX, we allow access to dashboards and reports with insightful information into programs, such as how well the program is doing at improving well-being, which services are being used the most, the reasons as to why people are being referred in, and that can allow programs to make improvements and spot where there might be gaps in their service. And also we allow the community providers themselves to log into Social RX and manage their referrals and provide updates to the social prescribing team. And that allows it to be a full end-to-end service for social prescribing. That's just a quick overview. I'm now going to go into Social RX so you can see. So here it is. It's completely web-based. So referrals come in, like I said, through GP. We've got two-way interoperability, which means that a GP has an integrated referral form on the clinical system, so they can click the Social Rx button and it auto-populates patient and practice details, and they can send it off. When they do that, that sends an automatic SNOMED code into the clinical system to ensure that every single referral is tracked and counted, which then contributes towards the DES targets for social prescribing. So if a PCN can make 12 referrals into social prescribing per 1,000 patients, they're eligible for £4,000. Like I said, the other method, you can do self-referrals, which means that the patients don't even have to go to the GP in the first place. So we're helping to reduce the overburden on the GP services, and also third-party referrals as well. So all of these referrals come into the caseload dashboard here, where they can be picked up by the link worker team. They can be assigned if a manager assigns different cases, or you can pick up cases as a link worker. So I'm going to go into John Smith's case here. So as you can see in the centre here, this is the whole referral pathway from receiving the referral details all the way to the discharge at the end, so you can see exactly what you've got to do, and it's a nice pathway to follow. At the top, we've got all the key details for that patient, including their contact details, and also we've got this tagging functionality as well, whereby you can tag cases with anything you want to set as a customer. You can set any sort of tags. So for example, it could be a vaccination status, whether they require a home visit, their housing status, and you can report on those tags and search by those tags so that you can see exactly what you can report on, exactly what you want to in this as well. So if we have a look at the referral details here, this is where the information is pushed through from the referral. If there are any risks in here, they will get flagged at the top here, just so that they're easily accessible, and you can add any more if they pop up over time. So let's say you've made initial contact with the patient, you can then collect equal opportunities data with them, and you can capture consent as well. At the point at which you accept or reject the patient, that again sends a second SNOMED code into the GP clinical system to let them know whether they've been accepted or rejected. We're currently integrated with EMIS, Web and System 1, but we are looking to do further integrations such as with Vision or Liquid Logic, which is social care. So if I move on to the second part here, which is scheduling an appointment. So we can go on to add activity. Let's say we've got a face-to-face meeting, 3 PM. You can put in your scheduled date and time in there. And you can also send a calendar reminder to yourself. So all those meetings can be scheduled down here. You've got the communication notes where you can add the whole history of the social prescribing journey with that patient. And again, they're stored at the top so that they can be viewed easily. The next tab across is the baseline assessment. So we've got a few different templates here. ONS4 is currently one of the assessment templates that the NHS recommends and suggests for social prescribing. But if there were others that a customer uses, we add those in here. So I'll just show you what it looks like. So if I fill in this health and wellbeing prism, so you can fill this in with the patient, click save, and then that presents the results graphically. So you can see where they are in the graph. And if you wanted to, you can export those, print it off. The next section across is the action plan. So this is completely configurable. You can capture exactly what you wanted to capture here. It may be the patient's goals, it may be what the link worker is going to do, what the patient's going to do. So that can be recorded here, saved, and then you've got different versions here as well. We've just added in our new release the ability to add different action plan templates, so that if you wanted to expand the social prescribing program to cover things like weight management, smoking cessation, long COVID rehabilitation, you could add different plans in there and choose which plan you want to cover with that patient. The conversation records are quite useful for commissioners. So how it works is that you've got a list of themes on the left. Again, that's configurable, whatever themes you wanted to record there. So things, for example, financial concerns, lifestyle issues. So you can select a theme, input any information there, click save, and then that's recorded. Each of these themes are read coded so that as a commissioner or social prescribing manager, you can see which themes are popping up most with your patients. So if you found that most patients are talking about financial concerns, for example, that can maybe help determine where you need more resource or where you need more services available in that area. Obviously, you can't report on communication notes or case notes, so this provides a way of being able to do that, and it just gives you an extra insight into the problems or what your patients are discussing. So moving on to the services section, this is where the link worker can book the patient into a community service, having had maybe a few meetings with them and found exactly what is important to them and what could help them with improving their well-being. So you could either do a quick search, say AGK, if you know exactly where you want to refer the patient. That brings up a booking form. You can put a date and time, any notes, select the service that the AGK offers. If AGK had a login into Social RX, you could book in the referral and that would send it straight to them. Otherwise, you can just opt for it to send an email to the provider instead. The other type of search we've got is an advanced search. So here you could search by a combination of category, service, so that's the things like the counselling, one-to-one helplines, things like that, groups. You can also search by postcode. So this could be either your patient's postcode or maybe the social prescribing hub's postcode. And by doing that, you can see where all those services are in relation to that postcode. So you can see the distance from maybe the patient's home, and you can set expectations as to whether getting there is actually achievable. So if you choose this one, again, you've got the booking form there. Select a site, and then that's booked in for the patient there. The providers can add notes to this, so they can add if the patient attended, and they can also add notes about the patient's trip to the service as well. So the next section is for follow-up assessments. This may be 6 weeks after you make that booking. It may be every 2 months. So in here you can fill in add in any number of follow-up meetings, and they will go into a link worker's bucket of scheduled tasks that they need to complete. You can fill in another assessment. So I'll just show you what it looks like when you fill in a second or a third or a fourth assessment. So you can see it's overlaid there with the initial one and the current one, so you can see if there's been any changes and if there've been positive or negative changes in well-being. You can see that really clearly on that graph. So the last section in here, we've got the discharge. So you can fill in an outcome review here with the patient. You can record specific outcomes that may be PIP awarded, hearing aid replaced, started volunteering. That again is a configurable list, so whatever the program managers wanted to record for social prescribing, they can do that there. And then once you change the status to discharged and select a reason, that sends a final note into the GP system to let them know that the social prescribing is complete. Just to point out as well, throughout the whole journey, the GP can see case notes that are filed back in, they can see assessment scores, and they can see service booking information as well. So it allows the GP to have visibility of what happens in the social prescribing program, as opposed to just referring them and then never hearing anything again. So this is the complete journey, the pathway of managing a patient. I'm now going to go into my favourite bit, which is the dashboards and reports. So the dashboards are more of a visual representation of the data with charts and graphs, and then the reports are the raw numbers, tabular data. And we've got all these different types as well. We're constantly adding to these, and if there was something that a customer wanted to report on that we don't currently report on, we add those in as well. So I'll just show you a few different types that we've got. So the overview one is self-explanatory. You can see the breakdown of referrals over months. You can see where the majority of those referrals are coming from, and also which job roles are referring in the most. You can apply any filters on the side here, so you could put it by month, by quarter, by year. You could also select a filter by PCN or by individual practice or borough. As well as that, all of these are really easily exportable, so you can either export the whole page to PDF, image or Excel, or if you just wanted this bit, you can expand this, export it and send it off in 10 seconds in an email. So the reason for referral one is really interesting in seeing why people are actually coming into social prescribing. So you can see here we've got a lot of stress or anxiety cases in the demo system, and then you can see the breakdown of all those reasons. You can see it by PCN as well down there. I'll show you this final dashboard here. So this is very popular amongst GPs and commissioners. So if I just put on a filter here, so I've got a bit more data. So I mentioned earlier the social prescribing DES targets. So here in this middle section here, you can see which practices are on target for those DES targets. So it's colour coded, where red means not on target at all, and amber means on target for the lower threshold, which is 8 referrals per 1,000 patients. And then a green one would mean they're on target for the upper threshold of 12 referrals per 1,000 patients. So this section here can allow you to see which practices need to boost their number of referrals if the PCN is going to be eligible for that £4,000. I'll just go into one of our reports. This is the assessment report. A date filter at the top there. So on this report, you can see how many cases you've got in Social RX that have completed more than one wellbeing assessment. Out of all those cases, how many have improved in their wellbeing, how many have declined in their well-being, and then the overall difference from the first assessment or the initial assessment to the most recent assessment. So this tool here can be really powerful in seeing whether the social prescribing program is meeting its top KPIs, in that is it actually helping people improve their well-being. I've not got it on the demo system, but we do have in the current live version filters on this, so you could see things like whether the reason for referral plays a role in how people's well-being is changing. So, for example, if people who've been referred in for loneliness are not improving that much, and then people being referred in for financial concerns are improving more, again, that's something that could help the program improve and find gaps in funding and resources, and make sure that everyone's being covered. I think that's all of the dashboards and reports that I wanted to show you. As you can see, we've got all different types on here. And yeah, I know I finished a bit early, but I did start a bit early. So I'll stop sharing my screen. Does anyone have any questions on that?
That was great, Maisie. Good insight into your products. So thanks for that. Things that stood out for me was just the ability to manage the social prescribing elements and referrals. Yeah, strong integration into the clinical system. So obviously that's going to streamline the pathway. So that's good. And the dashboards look really impressive as well, especially at that sort of holistical view across practices. So there were the takes that I took from it. I've got a couple of questions similar to Rakib. So what projects are you actively involved with at the moment with your product?
We've currently got 8 different organisations across the country who are using Social RX, and that ranges from PCNs, CCGs, and also the voluntary sector. And they're all giving really good feedback on Social RX. We are hoping to start soon a project with NHS Property Services, who they rent out and do up buildings and locations all across the country to NHS services, and they also do that to social prescribing. So whilst they're just renting out the buildings, they're also managing cases and wanting to report on the social prescribing, how it's going. So we're hoping that if we can work with them, and they seem very keen on working with us, we can help engage different areas to use Social RX and improve the ability to report on what they're doing and proving the benefits.
Yeah, that makes sense. And what are your ambitions for the products, specifically in our region, in the Yorkshire and Humber region?
Yeah, well, we're Leeds based. We work in the city centre, so it would be amazing if we had GP practices, voluntary sector in Leeds using our product. And also we'd love to, I mentioned integrating into social care. So if we were to have Social RX being used across social care as well, and integrating with, I think it's Liquid Logic is the system they use, and also Mosaic, I think. That's definitely an ambition for the short term, to get that integration so that in Yorkshire and Humber they can be using Social RX in social care.
Yeah, that makes sense. And how can people contact you for any follow-up discussions or conversations? We
have our email address, info@socialrx.co.uk, or emailing me, calling me is fine. Tim, will you be sharing out our contact details, or do you want me to post them in the chat?
I'll share them out, with any requests. That's great. Thanks, Maisie.
Thanks everyone for listening and for coming today.
Okay, so we'll move on to Pretty, who's head of sales at Your Meds. So they have a product that helps citizens manage their medication, ensure that they take the right medication at the right time. So I'm pleased to hand over to Pretty for her section.
Thanks, Tim. Share my presentation. Doing it at the front. You never know with Teams which way it's going to do it. Can you see that okay?
Yeah, we can see it.
Okay, well, you get to see my notes as well. So, Your Meds is all about helping people take the right medication at the right time with support of their networking, family and friends. By helping people become more adherent with their medication, you effectively improve their health outcomes, which helps increase their independence and their life choices. What we find is that working with adult social care teams across the UK, we also help increase capacity and reduce costs within the system. So when you fall ill, the first thing that the NHS will do is diagnose and investigate your symptoms. Once you've got that diagnosis, the GP will issue you with the prescription that you hope will either cure or manage your condition. According to the NHS and World Health Organization, only 50% of all medication is taken as intended. In the UK, we spent £9.6 billion on prescription drugs in the community. And the NHS, through the New Medicine Service, widely recognises that increasing adherence just to 80% just across 5 diseases like type 2 diabetes, high cholesterol, hypertension, would actually save the NHS £500 million every year. But the true cost of poor medication adherence in the community is actually felt within social care. West Lothian Council identified that one 15-minute visit, daily visit, costs the council £8,400 a year. So by helping people become more independent with taking their own medication and putting them back in charge, you can actually negate those visits. You can't negate all of them because some of them will be associated with personal care visits, but if people are taking up to 4 rounds of meds a day, there's the middle 2 that can definitely be taken out. So that allows the council care teams to actually increase capacity within the system. West Lothian Council found that they saw a 9 times return on investment, but importantly, it allows them to use the data that our system collects to inform that decision making. And what West Lothian Council do is that daily task of taking a medication every day, they use as a cognitive assessment tool. So what affects adherence? There are lots of things that affect adherence, and I'm not claiming we can fix them all because quite a lot of them are system issues, things like religious and social factors and poverty and financial hardships. But what we've made sure when we developed Your Meds was that people with poor technological literacy can actually use Your Meds. It's really simple and easy to use at the point of the user. In fact, we've just started supporting a user in Manchester who is illiterate. So he has someone going in to support him with opening up his mail and reading his mail to him. But for the first time, he can actually self-administer his own medication through our technology. We've also ensured that if you've got technology poverty, that we can support you with that. So we ensured that there was a mobile SIM already built into the system. So you don't need Wi-Fi and broadband to be able to access our system. And why does every dose matter? Well, when drugs are developed and the drug companies spend millions of pounds trying to develop these drugs, they ensure that people take their medication at the right time to basically show that the efficacy of the medication works. And especially in conditions like Parkinson's, epilepsy, migraines, MS, and all the ones that are listed here, it's really important that people take their medication at the right time, at the right intervals. So the value proposition around Your Meds really addresses the growing and ageing population. Our technology supports patients and carers to supported self-management, and 15 million people in the UK actually have a long-term health condition. Someone over the age of 80 has a 1 in 2 chance of falling. The annual cost of falls is £4.4 billion. 1.1 billion of that is felt in social care, and 2 billion is actually felt just by hip fractures account for 2.2 billion of that sum. When Your Meds started its journey, actually, we developed the first colour-coded MAR charts, and our first part of our business is actually focused within the care home side. And from our care home database, we know that we've got about 50,000 people on our care home database, that 1 in 6 of them will take a drug like warfarin, dioxin or codeine, which can cause drowsiness and may make people fall. Councils and organisations spend millions of pounds trying to put in sensors and try and anticipate when people are going to fall, and a lot of money goes into preventing people to fall, but actually nobody looks at the medication piece. So how do you know that someone hasn't fallen because they took their nighttime meds in the morning? And really, we think that integrating that medication data is really a crucial part of that jigsaw to understand how to improve a user's outcomes. Another area where we feel that Your Meds can really support people is with care fatigue. We've got a programme happening in Manchester at the moment with Parkinson's. I'm going to talk a little bit more about that later on, but actually the way our system works means that the care of fatigue on that primary carer can be reduced by using Your Meds. So what is our system? Well, Your Meds, this is it in its actual physical form, very similar to an advent calendar. You see a number on the tag and then you open up the corresponding number on the box when it's time to take your medication. The packs are filled and dispensed by the pharmacy, and like I said, you've got a SIM in there that basically connects to the strongest signal in the property. So it's not attached to a certain provider, it will just pick up the strongest signal, and that signal could change across the day. So in the morning it could be EE, and in the afternoon it could be Vodafone. The second part of the system is the supporter app. So a user can nominate up to 5 people from their support network to support them to become more adherent. 10 minutes after the initial alarm, the first supporter is informed. And on the supporter app, which is available on Google and Android, the supporters can see what medication was due yesterday, what's due today, and what's due tomorrow. The third part of our system is the dashboard. So here we can log every single medication round, so we know what time it was taken, if it was taken late, early, if it was missed, if the wrong ones have been taken, if multiple wrongs have been taken. And we can also see every single supporter notification. So it gives you a full audit trail of all the medication and everything around that. Our technology is also insured by Lloyd's of London. So if you've got carers who are working within the system who aren't insured to provide medication support, they can do effectively with the Your Med system. Like I said, we love data. We're all about data. So we crunched some data and we found that on average, our adherence rate is 84.4%. During the lockdown period, when people were a lot more unsupported, the adherence went down slightly to 82.2, but it's still well over the 80% that the NHS is trying to achieve. Our male users are slightly more adherent than our female users, and actually our older cohort, our over 79-year-olds, are actually the most adherent at 90.5%. What we also found was that 1 in 4 of our rounds is adherent due to a supporter nudge, and the supporter nudge is really the crucial part of our Your Med system. So we know that everyone needs a little bit of help every now and then to help them achieve their goals, and Your Med provides a really effective way for you to achieve that. A big question I often get asked is pharmacies. So how do we onboard our pharmacies? Well, over the last 15 months, we've recruited over 250 pharmacy partners across the UK, and the way we've recruited them is by working with the various councils that we work with. We will look at that area and then onboard the local independent pharmacies. Your Meds fits within that pharmacy workflow, so it's very similar to the community packs and standard dossier boxes that are issued, and there's about 1.5 million of those issued every week in England. So because it works within that pharmacy workflow, it takes maybe another 30 seconds really to apply the seal on the Your Med system. So it's, it works well within that workflow, so pharmacies don't have a pushback against it. It's also scalable, so we've made sure that our technology can integrate into the pharmacy robots that more and more larger pharmacies are using. Within the UK, we work with 9 organisations at the moment, and there's probably another 5 to 10 that are due to start imminently. Wigan's a new council that we've just started working with, so we're working with their care providers, and that's again to increase capacity within the system because they've recognised that there's a huge adult social care staffing issue, and actually if they can help their care providers work more effectively and smarter, then they're going to support them to do that. Just quickly about the Parkinson's program that we've got running in Manchester. I'm sorry, this is really small. But hopefully we can just send you the slides so you can have a look at it. So this logic model was created with Wessex AHSN, and we worked with Parkinson's nurses in Manchester to identify users who are using their service but are also struggling with their medication adherence. Some of those users are up to 10 rounds a day. And what we hope to see from the pilot that we ran was an improvement in adherence, a reduction in primary and secondary care demand, a reduction in care fatigue, and also to increase the independence of the patients to delay more expensive care costs. The initial feedback is that on average, our adherence rate is 87% with our Parkinson's cohort. Users have experienced greater independence. 40% of the users have been discharged from the service, and we can't say it's all due to Your Meds. A number of factors are involved in that, but actually by people becoming more adherent, that was one of the factors why they were discharged from the service. I'm loving some of these statements. So it lets my wife rest as I can remember when to take my own medication, and Your Meds has saved my life. It's given me my life back. I was all over the place before. So, and you know, getting those sort of feedback is the reason I work in digital healthcare, because I just think that if a simple piece of technology can change a person's outcomes, then I'm all for it, and that's why I want to get involved with this. Working with councils, we support people with long-term health conditions. So we've seen the daily challenges that reablement teams face, especially managing hospital discharge and supporting service users with their medication in their own home. West Lothian Council saw a 9 times return on investment, saving £3,376 per user. We did a pilot in Leeds a while ago, which showed that by extending a user's time in their own home by 88 days, the council actually saved £7,190. This is kind of a workflow that we would like in our utopian position. So we'd love our data to be integrated into the primary, into sort of GP records, so that when you go and see the GP, he can look at your adherence record and say, actually, the reason that your blood pressure tablets aren't working is because you've not taken them. And you know, it could provide a whole system-wide benefit from primary through to secondary care, reduce fewer hospital admissions, and a reduced demand in primary care. The joining up of health and social care through the ICSs is also a really exciting time, I'm hoping. And along with the white paper, putting people at the heart of care, it provides an opportunity to create a system that uses digital technology to bring medication management into the 21st century. What I'm looking for is really people who are open to look at this medication management piece, which I think has effectively been ignored for like forever. There's no responsibility as to who is in charge of the medication once it's given to the user. We assume that the user will take it, but we know that that's not what happens. So it'd be great to bring a piece of digital technology into the system and to change the way medication is managed in the community for the 21st century. Let's stop presenting.
Is that the 28th? Oh, that's the same like before. Okay.
That was great, Pretty. Thanks for your overview and some interesting stats and also feedback there. So thanks for that presentation. You covered off the projects that you're actively involved with at the moment. So yeah, quite a wide range of projects. What are your ambitions for the Yorkshire and Humber region? What's the sort of ask within that region?
So we've started a discussion with Leeds Council and Calderdale and Kirklees, and I think they're all trying to join up to do a larger scale sort of implementation, and because they're all fairly close to each other. So I'd love to see something really within the ICS footprint, something on a larger scale that we could push out. One of the things that we are lacking at the moment is the evidence. I mean, we've got user outcomes and we've got evidence and we're working with various councils to try and pull together this evidence, but really to have a larger scale program and to really build that evidence to sort of say, yes, this works, let's go for it, let's push this out. So
okay, and how can people contact you for any follow-up conversations?
You can happily stalk me on LinkedIn. I'm all over that, and hopefully you share the slides because they were quite tiny, and my contact details are at the end of that slide. but yeah, and just pick up the phone and give us a call. Happy to do a Teams meeting and talk about what the issues are within the system. I'd love to have a wider discussion with people about medication and how it works within hospital discharge and how it works within the community. Because I think the NHS and social care do kind of butt heads around the medication piece. And we know that a lot of our conversations with social care get stonewalled when it goes towards the NHS, but I'm hoping that this whole joining up of health and social care will enable those conversations to flow more easily.
Yeah. Okay, that brings us to a conclusion of the 3 suppliers that are on the Propel cohort. Has anyone on the call got any follow-on questions for the cohort? No worries if there isn't any. Feel free to reach out to us after the session. So we'll bring it to a close. Thanks everyone for your time. We'll put the recordings onto our YouTube channel and circulate it, and you'll be able to share that with any key stakeholders. So I will stop the recording.